Greetings to all the medicos out there. In the following series of videos, I'll cover epidemiology of communicable diseases. Today we'll start with respiratory infections. First we'll go with measles, and I would request you all to ignore the spelling mistakes present in the presentation. I took help of my non-medico friend in order to help me type this. So please ignore the spelling mistakes, and wherever they are there, I'll try to correct them. I'll try to say you. And okay, let's get started with measles. So measles it's a disease of childhood, and it was a disease of childhood, and it is an acute, highly infectious disease. And measles virus belongs to the paramyxoviridae, and it is characterized by maculopapular rash with fever and coryza. Man is the only host and reservoir of the virus. The problem statement is the lack of awareness regarding vaccination, denying to take vaccine, changing trends from children to adults. Due to vaccine coverage present in the children and waning immunity in the adults, there is a changing trend from children to adults. The adults are affected now. And the inter-epidemic cycle is 2 to 3 years. That is, there is peak of infections occurring every 2 to 3 years. According to WHO, measles is responsible for 2% of under 5 mortality rate in India. Okay, it's a major chunk. Next, epidemiological determinants. Under epidemiological determinants, we discuss the agent factors, host factors, and environment factors. The proforma for any disease is the same, and like that. And epidemiological determinants is spelling mistake, and the agent factors is a belongs to the paramyxoviridae. It's a single stranded RNA. So we are coming from like inside nucleus, capsid, then envelope, and its shape. In an order we are coming. So there is single stranded RNA, carbohelical capsid, which is got by an envelope which contains hemagglutinin, F protein, M protein, but there is no neuraminidase present. It is pleomorphic, and most common shape it's actually pleomorphic, but most commonly it occurs in the spherical shape. It is heat labile, susceptible to ether and formaldehyde. It is antigenically uniform. The heat labile susceptibility to ether and formaldehyde are important. Okay, its heat labile nature favors only person-to-person transmission, not by fomites or something. Okay, and antigenically uniform. There is a characteristic cytopathic effect of Warthin-Finkelty chain cells. Is acidophilic multinucleate chain cell inclusions present in both nucleus and cytoplasm. The source of infection is only a case of measles. The measles patient can transmit the infection 4 days before and 4 days after the rash. The period of communicability is 4 days before and 4 days after appearance of rash. The sources are respiratory secretions, vesicular fluids, and these are all sources which spread the infection. The communicability decreases after appearance of rash, and the period of isolation is 6 days after appearance of rash. These are important, and infection confers lifelong immunity. And next, moving on to the host factors. Age, the most common age group affected is 6 months to 3 years, and in developed countries it is more than 5 years. The prevalence of measles in adults after vaccine intervention has increased. The prevalence of measles in adults has increased after vaccine intervention because there is waning immunity in adults and the vaccine coverage in the children is adequate. So there is a changing trend as we have discussed in the problem statement. And there is no sex predilection. Coming to the immunity, the less than 6 months age infants are immune to the infection by the maternal antibodies present. And the vaccination doesn't confer a lifelong immunity. The one infection, there is lifelong immunity. Nutrition, malnutrition causes measles, and measles, complication of measles is also malnutrition. There is a relation between them. And coming to the environmental factors, can occur in any season, but the most cases are between January to April, late winter to early spring. That is late winter to early spring, and the incubation period is 10 to 14 days. On the day 10 we have fever, day 12 we have the complex spots, and on day 14 we have the rash. And the rash starts from behind the ear, spreads to the face and then to the body. The complex spots are very characteristic and pathognomic of measles. They are sand-like granules present in the buccal mucosa opposite the lower molars, and They are very pathognomic of measles. Okay, we will discuss detailedly in the clinical features. And the incubation period of the vaccine virus is 7 days only, or any route which bypasses the respiratory route, it is only 7 days. That is a key point. And the clinical features, they are divided into pre-eruptive, eruptive and post-measles stage. Pre-eruptive, 10 to 14 days of infection. From 10 to 14 days of infection, it's characterized by fever, cough, coryza, this is not coryza, conjunctivitis, lacrimation and photophobia. On day 11 or 12, there are Koplik spots. I have told that there are pathognomic of measles, sand-like white or grey lesions surrounded by erythema on buccal mucosa opposite to the lower molars. This is the characteristic, this is the perfect description of the Koplik spots, you have to remember. And in the eruptive stage, there is a rash, and it starts from behind the ear and then to the face and then to the body. The rash heals by leaving brownish discolorations, and this persists for 2 months. Okay, and the rash is due to action of T cells on virus. Here we have to see the point. Appearance of rash indicates appearance of CMI, fall in viremia, and fever occurs as a result. Okay, and next, on the post-measles stage, there is weight loss, can land in chronic illness due to recurrent bacterial viral infections, tissue destruction, nutritional and metabolic effects are present, and the suppression of delayed hypersensitivity reaction can cause exacerbation of underlying tuberculosis. And then diagnosis, it's generally made clinically by complex spots and rash, and the diagnosis spelling, we ignore that. And in developed countries, the diagnosis by detection of IgM by ELISA. It's not it's a spelling mistake. It's ELISA, viral RNA by RT-PCR. And then complications. The acute, this is not active. Acute complications are otitis media, most common, and pneumonia is the most severe. It is pneumonia. That's the most severe. Chronic SSPE, subacute sclerosing panencephalitis, is a chronic complication. The complications can also be divided like in children or adults, in immunocompromised and pregnant. In immunocompromised, the complication is giant cell pneumonia. In pregnant females, it induces labor spontaneously, and there is abortions, premature delivery, but it's not teratogenic, as unlike the chickenpox virus or some other infections which are teratogenic, but this is not teratogenic. It just induces the labor, spontaneous abortions, and premature deliveries. There is also thrombocytopenia present, and then in children or adults, the complications may be due to the virus or due to the bacteria. Due to virus, it's group bronchitis, and due to the bacteria, it is otitis media and pneumonia. Okay, SSP we have discussed, it's a chronic complication, and meningoencephalitis is also a chronic complication. So who are likely to develop complications? It's children of developing country, malnourished, vitamin A deficiency, immunocompromised individuals, overcrowded conditions, people living there. All these are prone to develop complications like protracted diarrhea, giant cell pneumonia, severe malnutrition. Okay, and the treatment is by supportive care, nutritional support, risk of malnutrition due to diarrhea, vomiting, and poor appetite. So, as there is a risk, we have to provide nutritional support, and breastfeeding should be done, oral rehydration should be given. All these are the treatment. It's just supportive care, right? And the patient isolation should be from catarrhal stage to 7 days after onset of rash. Okay. As many children develop acute deficiency of vitamin A, they must be given vitamin A supplement to prevent keratomalacia and scarring, which finally leads to blindness. Okay, the vitamin A supplementation is required in any measles case. The schedule of vitamin A administration is immediately after the diagnosis, a first dose will be given, and on the next day, the next second dose should be given, and the third dose after 4 to 6 weeks if signs of deficiency are still present. Okay, and the dosage is based on the age. Less than 6 months, it's just 50,000 international units. 6 to 11 months, 1 lakh international units, and about 12 months of age, it's 2 lakh international units. Okay, now moving on to the prevention. Best prevented by active immunization. The evolution of vaccine. Active immunization is done by a vaccine, and the vaccine has evolved in 3 stages. Edmonton strain. Edmonton strain was first introduced. It is not used as it is causing febrile rash. Then we have it has evolved into Schwartz, Morat, and Stain. And the disadvantage with this is it can't be given to children less than 12 months of age. Then we have gone to Edmonston Jagreb strain. It was effective even at the age of 4 to 6 months. So this is the strain currently using, and produced by serial passage in human diploid cell. The Edmonston Jagreb strain is produced in the following way. And next, the recommended age groups are in developing countries 9 months of age, and developed countries it's 15 months of age. Okay, the schedule of the vaccine is first dose should be given at 12 to 15 months of age, and the second dose should be given at 4 to 6 years of age. So we'll learn some points regarding the vaccine. It is a live attenuated vaccine. The dosage is 0.5 ml given in the subcutaneous route. It is freeze-dried or lyophilized. It's available as freeze-dried or lyophilized powder, which should be reconstituted using sterile water. After reconstitution, it should be stored in colored bottles or vials at for 2 to 8 degrees centigrade and should be used within 4 hours of reconstitution. It is given in the right upper arm, and the 0.5 ml, which is a dosage, contains more than 1000 infective units. Immunity after vaccination starts by 10th or 12th day and lasts lifelong. Okay, this is regarding the vaccination. And the efficiency of vaccine is like single dose provides 90% seroconversion, 2 doses there is 99% of seroconversion, and the susceptible contacts over age 9 to 12 months should be given vaccine within 3 days of exposure, as incubation period of vaccine virus is 7 days compared to 10 days of normal viruses we have discussed already. And the combined vaccinations are highly effective, like MR, MMR, MMRV. So this is measles, rubella, measles, mumps, rubella, measles, mumps, rubella, varicella. This is the combination of vaccines. The contraindications of vaccination are we should not give in pregnant individuals and allergic to neomycin or gelatin. This is not F. The F is not there. It's gelatin. And or in severe immunosuppression, it should not be given. In severe immunosuppression, live attenuated vaccines are not given. That's the thing. Next, the sequelae of vaccination. Generally, any vaccination will provide immunity. That's a normal sequelae. And other than that, there are fever and rash due to vaccine virus. This occurs 5 to 10 days after immunization. There is a D. And fever for 1 to 2 days, rash for 1 to 3 days. It's due to the vaccine virus. It subsides gradually, not so bothersome. And then the sequelae due to vaccine which is used after 4 hours of reconstitution. This is very dangerous. It causes toxic shock syndrome characterized by severe diarrhea, vomiting, fever, and death within 48 hours. And the vaccine schedule in areas with high HIV and measles incidence, there is 6 months of age the first dose is given, and the remaining 2 doses according to the national immunization schedule. Actually the schedule was like 9 to 12 months there is first dose. Wait, I'll put that. Okay, 12 to 15 months there is the first dose, and 4 to 6 years there is a second dose. But when there is in areas of high prevalence of measles and HIV, we give 1 dose at 6 months of age, and the 2 remaining doses are according to the national immunization schedule. Eradication of measles required 96% of immunization coverage in children under 1 year of age. There is also immunoglobulin against measles, which is dosage is 0.25 ml per kg body weight, given within 3 to 4 days of exposure, and then active immunization given after 8 to 12 weeks of passive immunization. So after passive immunization, we give active immunization 8 to 12 weeks later. The outbreak control measures are isolation of cases for 7 days, susceptible contacts given vaccine within 3 days of exposure, prompt immunization to limit spread. With scheduled age of receiving measles vaccine at 9 months, it can be lower to 6 months if there is a measles epidemic. Okay, the MR campaign, I think you can read this and understand. There is nothing much to explain. There is a follow-up campaign and all that. This is an important thing, and it is launched in 2017. It replaces the measles elimination campaign as measles rubella campaign. Okay, I think you can pause the video and note this down. That's it. Thank you.